Our next speaker is Dr. Wilmore Webley. Dr. Webley is a professor of microbiology and the Senior Vice Provost for Equity and Inclusion at the University of Massachusetts Amherst. He has over 25 years of experience in teaching and research on infectious diseases, immunology, and vaccine development. He has published many peer-reviewed articles and book chapters and has received numerous awards and grants for his work. He is also a member of the editorial board of several journals. Dr. Webley is passionate about mentoring the next generation of scientists and engaging with the public on health-related issues. Dr. Webley will present on the effectiveness of vaccines to prevent long COVID. Dr. Webley, you have the floor.
Thank you so much, Dr. Kavanaugh, for having me. Thank you to the other amazing speakers for their stories and for really putting in context this really important problem that we have in terms of long COVID and the ongoing pandemic. I have a few words of disclosure here that I have no intellectual property or financial interest in any of the products that I talk about in this presentation. This really is to give information, and hopefully people are able to make up their minds about this information and make meaningful decisions based on that. So I'm not going to linger much on what long COVID is because I think the previous speakers have done a really good job on really centering this and understanding the symptomology that is related to long COVID and have gone into great description. What I want to do is take a little bit of a different view. Here's a paper by Vadani's group that looked at the major factors that may be involved in the pathophysiological mechanisms underlying long COVID. And what they have put together here are several factors that could lead to long COVID. Among them, the fact that you have persisting viremia for SARS-CoV-2, and that, along with reactivation of dormant viruses in the system, along with a physiological damage of certain organ systems, could lead then to further dysbiosis in the gut, could activate autoimmune phenomena. You have an hyperactivation of the immune system that comes from both innate and adaptive immune responders overall. And so from that, they have formed 5 hypotheses, intersecting hypotheses, about the mechanisms for long COVID. And basically, those are viral persistence, reactivation of latent viruses, viral superantigens, like some that we've seen, including HSP60, disturbance in the gut microbiome that then now can impact other areas, and you have a multi-tissue damage and autoimmunity. So this is their breakdown of what they feel contribute to the pathophysiological mechanisms that we're seeing in long COVID. But I want to bring you back to the ubiquity of ACE2 receptors as well as co-receptors for SARS-CoV-2. And before this pandemic, many of us didn't realize how widespread the overall prevalence of ACE2 was and its content on some of these cell types. So not just in the respiratory system, nasal passages and the lung, of course, but of course in the intestines, the heart, the eye, liver, bladder, kidney, pancreas. We know the brain, all the blood vessels there are loaded with it, and of course the testes and the placenta. And I think just understanding the fact that all of these organs have cells within them that have ACE2 on them that will allow the entrance of SARS-CoV-2 can help explain this systemic infection that we see from SARS-CoV-2. So when one look at the organ systems that are affected by long COVID, what one sees is a map of all of the organ systems that have cells with high densities of ACE2 receptors on them. So that actually correlates pretty well. Now, this study by Stein and Company that came out last year was a really important one. They did an autopsy of 11 patients who had passed away because of COVID. And then they systematically went through and sampled each organ and the brain, looking for the presence of the SARS-CoV-2. And these patients here are aligned at the top here based on duration of their illness before they passed away. So patient P36 passed away sooner than P42, who passed away at day 230. And then you can see over here where they're separated, the organ systems here, where you have your respiratory system, the cardiovascular system, lymphatic system, your GI and genital nervous system, endocrine, and these are smooth muscle, central nervous system, ocular system, and of course your peripheral nervous system. And what they're showing here is that over time, you can look and very quickly see that the respiratory tract, from the salivary glands to the deep in the lungs, up until day 230, you're still detecting pretty decent levels. This is a heat map showing numbers of viral particles of RNA that you're finding. What you're seeing here is that you're going all the way out to the patient who lived the longest with SARS-CoV-2 before passing away, having the presence of the virus. And you can just scan down, and you see that this is also true for the cardiovascular system and the musculature. You can see that this is also true for the sciatic nerve. And then you come down to the central nervous system, and this, to some extent, was surprising to me, that you were seeing all of the areas of the brain pretty much had the presence of SARS-CoV-2 right out to the patient who lived the longest with this disease before passing away. And this over here is a fluorescent image looking at neurons, and you can see the green-stained SARS-CoV-2 virus inside of the neuronal cells. In other words, what we're seeing is that there's several organs in the body and systems in the body where you're having persistent infection of SARS-CoV-2, even after the patient is testing negative by our conventional PCR tests. And so, of course, the lung suffers greatly from long COVID. This is an interesting high phase contrast image of the lung of a COVID patient who eventually passed away. But at this point, it was relatively early on before they were intubated. And what you're seeing here in the cyan type color are alveoli that are still unblocked and functioning. You're seeing bronchioles there. And then you're seeing the blood vessels that are still unobstructed and functioning. You're seeing them in red. But look all over, you're seeing the yellow here. And these are blood vessels that have been blocked by microclots in the lungs of patients who have COVID. So when you look at the 3D of that, you can see that you're having massive obstruction of these organs by microclots, and damage to blood vessels cause viral reactions. One of the things that we've seen more and more is post-COVID diabetes. In this current study that I'm looking at by Mueller, patients in the study were about 40% more likely than the control group to develop type 2 diabetes. And this is post-COVID diabetes. And essentially, what came out after the doctors started seeing this phenomenon is essentially that COVID actually infects directly the beta cells in the pancreas. Turns out that we're born with all the beta cells we'll ever have. And after you've knocked off enough of them to a certain threshold, then you lose the ability to produce enough insulin. That's what the beta cells do, in order to mitigate the intake of carbohydrates, starches, sugars. And so, again, this is a major issue. And so this group at Cedars-Sinai actually has a really good summary on why this is so very important when they look at the study of COVID-19 infections and its risk for diabetes.
In our population, there was an increased risk of diabetes after COVID infection. This risk persisted across the Delta and Omicron timeframes, and there may be a slightly decreased risk in the patients who received vaccination prior to infection.
What we know of cardiovascular risk factors, there are a handful of major ones. There's hypertension, there's high cholesterol, diabetes, smoking, obesity, and others. Diabetes we think of as the single most important in terms of the magnitude of its effect. Our suspicion, our hunch, is that the individuals who developed diabetes, a new onset diagnosis of diabetes, were individuals who probably had a predisposition for developing diabetes at some point in their lives. And so what we're thinking now is, based on the trends and the patterns in the data that we see, is that COVID infection may be acting something like an accelerator. A factor that actually speeds up the process of developing disease.
To us as cardiologists, this is somewhat concerning because most people in the United States will have a COVID infection at some time if they have not had it already. This study helps us understand and prepare for the future where COVID infection may be contributing to future cardiovascular risk. We're hoping to try and get ahead of this and understand the ways that we can mitigate this risk to help people live healthier and longer lives.
Research that has been ongoing now for a couple of years, this study from last year, that actually shows that even a mild case of COVID can actually lead to physiological changes in the brain. Here you're seeing the ratio of the brain volume, and in orange you're seeing COVID versus patients who did not have COVID. And you're seeing a significant reduction here in the size. In fact, after a year, they described it as looking at 10 years of decline in brain volume in patients that they've seen with dementia. And they concluded from the study that COVID-19 actually damages blood vessels in the brain of infected individuals. This study just came out a couple of weeks ago. Van Elker et al. Actually looked at neuroinflammation in patients with post-acute sequelae of COVID, which is the same as long COVID. And what they showed definitively is that patients with long COVID, those are the ones in red here, when you looked at the whole brain, or you were looking at the posterior mid-cingulate cortex, or you're looking at the corpus callosum, or the anterior cingulate, the striatum, the thalamus, whichever area you're looking at, there was a greater level of inflammation, of neuroinflammation in patients with long COVID compared to their control. For long-term cardiovascular outcomes, the data was pretty remarkable. The first study that came out last year by Xi et al. Demonstrating essentially that for patients who have had COVID, even for patients who were not hospitalized, and that's those in green here, you can see that there is an increased risk when they looked at the hazard ratio. Patients who were in the ICU, they're at greater risk for every category of cardiovascular disease when they check these patients a year after. So this is 12 months after the incident of having COVID. So even patients who don't appear to have anything going on, it goes back to what Dr. Burtz actually said. And then a couple of people actually mentioned this recent study looking at the reduction in serotonin in long COVID, which they now have linked to being able to drive brain fog. And the mechanism seems to be that you actually have induction of toll-like receptor 3, so normal adapter receptor for viruses, RNA viruses, when they get into the cell. That now activates NF-kappa B, leading to production of type 1 interferon, which again is a regular signal when you have viral infections. But that now leads to depletion of tryptophan in the gut, in enterocytes. And that tryptophan depletion actually leads to a reduction in serotonin and linking that now to hypercoagulation as well. But importantly, the lower level of serotonin leads to reduction in serotonin receptor agonists. And so you have a neurocognitive effect because of the vagus nerve is actually affected. And so again, we're seeing greater and greater links to this. So that when one looks at the overall summary then of the potential for viral immune responses and tissues, Chen et al. In a recent study broke it down this way, where he looks at replicating SARS-CoV-2, which is able to cause significant cytopathic effects like many viruses do, but also activate the innate immune response. Again, your type 1 interferons involved, presentation of viral antigens via MHC. And that now leads to inflammation that can be persistent. And in many patients, it appears that it is. And both nucleic acid as well as the antigens that are produced can lead to ongoing inflammation. And that ongoing inflammation can exhaust the immune system through various mechanisms, both T cells, natural killer cells, and possibly even B cells. And essentially what you have after that is that exhaustion could lead to the activation or reactivation of non-COVID latent, especially DNA viruses that have been integrated into the genome. And what are these viruses? It turns out that they have looked at IgM antibodies and be able to see that they're having reactivation of cytomegaloviruses, all of the human herpes simplex family of viruses, from Epstein-Barr virus to HSV1 to 6, varicella zoster, parvovirus B19 strain, human endogenous retrovirus K, which we know many people have. It's been associated with tumors. And of course, adenoviruses, adenovirus 5, probably most prominent among them. And they've even seen patients who are having trouble balancing and managing their HIV. JC and BK viruses are also increased in these individuals with long COVID. So when one looks at it, then the question is, what role do vaccines play in mitigating long COVID? Just this morning, the Annenberg Public Policy Center put out this graph that shows that more patients believe that ivermectin is effective in COVID treatment over the past 2 years. And so what you're seeing here is 26% of people surveyed believe that ivermectin was effective in treating long COVID. And when they were asked about whether or not COVID vaccines were safer than getting COVID-19, 21% of people said that vaccines were not safer than getting the disease. These are the challenges that we encounter where vaccination and COVID is concerned. Another 12% of people basically says that vaccines in general are full of toxins and harmful to patients, including having antifreeze in them. This would be an interesting study from the Annenberg Center to look at. And so the question then is, in light of the mechanisms that we've looked at, is there the probability that having vaccines that are effective would be able to have any effect on long COVID? And so a number of studies have come out. This study by Gaunzi et al., where they did a clinical trial in Austria, where they actually looked at a number of patients, major groups here, patients who were non-vaccinated and became infected. Then they looked at vaccinated group. They looked at patients who were vaccinated after they became infected and patients who became vaccinated prior to being infected. And the results were interesting. When they looked at the frequency of IgM positivity for some of these viruses that I just talked about that we see are being activated in long COVID, your herpes simplex virus, your cytomegalovirus, your Epstein-Barr virus, your parvoviruses, varicella zoster. They're looking at IgM, which means are you having an acute infection of these viruses? And you can see for all patients, you can see the trends here, looking at the time in days below. And then when you look for the patients who are unvaccinated, you can see that they have significant increase that lags for quite a long time, over 300 days. Very different picture for patients who are vaccinated. They do not have even half that many activations over the same period of time. There's another study here by Cody et al. That ran looking at the association between vaccination and reported incidence of post-COVID symptoms. This was a cross-sectional study that ran from 2020 to 2021 in Israel. And what they actually showed was that for patients who were unvaccinated, in blue here, you can see that they had significantly more fatigue, more weakness of limbs. They had significantly more muscle pain. They had significantly more hair loss. They had significantly more dizziness compared to getting 1 or 2 doses of vaccine overall. So these are significant findings. Another really excellent study that is a recent study looked at the protective effect of COVID-19 vaccination against long COVID. And this was a meta-analysis, a systematic review by Wantabe and his group. And they looked at 3 different subsets. Patients who got 2 doses of vaccine versus those who weren't vaccinated. And as you can see here, when you look at the odds ratio, you can see that the patients who were, for all of the studies that they included in this meta-analysis, patients fared better when they had 2 doses of vaccine versus those who were unvaccinated. And then you look at those who had 2 doses versus 1 dose. Again, you saw that those with 2 doses were better off. So it favored the 2 dose versus the 1 dose. And then you had the 1 dose vaccination versus those who weren't vaccinated. Not as impressive in terms of odds ratio, but still a difference there in those who got just a single dose overall. So essentially what you're seeing is that from this study, they're demonstrating that there is protective effect from being vaccinated. Here's another study by Bayan et al. Looking at the effect of COVID-19 vaccine doses on long COVID. And what they have demonstrated, again, is that whether or not you have 1 dose, 2 doses before infection, you get the best effect. 3 doses, that is, you get the best effect from 3 doses. In other words, your booster. And for patients who were vaccinated after they had the first sign of infection, they had less of a protection, but still protection nonetheless, especially when they got 2 doses of the vaccine. Here's an interesting study by Marin Nayabari and company that was just published last month. And what they looked at vaccination after developing long COVID, and they looked at the impact of that. So they had a cross-sectional study where they looked at patients who had no vaccine versus those who were vaccinated with 1 or 2 doses. And what they showed was that there was a significant reduction in the number of symptoms that patients were having after they got vaccinated, that the number of organs that were impacted was significantly less, and that the WHO well-being score was higher, significantly higher in your vaccinated group. You saw inflammatory markers like your CD40 ligand that's necessary for antigen presentation. You saw a significant reduction in that in vaccinated groups. Platelet-derived growth factor and its receptors are significantly reduced. And when you looked at the longitudinal study, pre-vaccination versus post-vaccination, whether it's a 1 dose or 2 dose, you see similar results where the number of symptoms are reduced. Overall, the well-being score is increased. All of these cytokine and chemokine markers are significantly reduced in your vaccinated group versus your non-vaccinated group. We see the same thing when we look and ask whether or not we are seeing a significant increase in patients who have long COVID and have gotten vaccinated. You can see that there's significant increase in antibodies these are IgG antibodies, to the receptor binding domain and the spike protein overall compared to unvaccinated group. And so on CIDRAP, they looked at a summary of this study. And essentially, when they looked at this, the 5 most common symptoms reported at the beginning of the study of these patients, 82% essentially had fatigue. Another 47% had trouble concentration. Nearly 40% had trouble with memory. 1/3 of them had headaches, shortness of breath as well. And after vaccination, 77% of the patients report an improvement in symptoms compared to 7% who said that they had worsened outcomes and 14.8% who said that they was unchanged, respectively. And we saw that 86% of participants had fewer number of symptoms overall, respectively. And so the conclusion was that we observed a significant reduction in systemic inflammatory cytokine and chemokine levels post-vaccination, independent the number of vaccine doses. They showed that 16 cytokines and chemokines were significantly decreased after vaccination. And so the conclusion was that high inflammatory cytokine and chemokine levels have been correlated with acute COVID-19 severity, poorer outcomes for patients. In other words, these are the inflammatory markers of the pathology. And essentially what they're observing is that vaccination is able to significantly reduce these inflammatory markers overall. And so the study showed that approximately 69%, when they looked at this Mara Kobayashi study, that it estimates that about 69% efficacy with 3 doses of the vaccine against long COVID for people who actually take it prior to getting infected with the virus. If you take it after your first infection, there's a reduction in that. So again, another couple of studies, this one by Sam Stason, again showing that vaccination in these meta-analyses of all of these studies actually significantly reduce the probability of long COVID signs. So the main takeaway here is that long COVID has affected approximately 7% of adults in the United States. I couldn't find consistent results on children because, as Elenia and others have said, they're just not putting that data together in a way that one can find it. But you see over and over again adults talking about the stress and strain of long COVID on individuals overall. And the data is now showing that vaccines can lower the risk of getting long COVID. Now, don't misunderstand this. It doesn't mean that vaccines have a full protection against long COVID. It's just that it lowers the risk. And all of the studies that we've seen so far seems to converge on this. And again, this review estimates that about 69% reduction if you've gotten 3 doses prior to becoming infected. Unfortunately, many people did not have that protection before they got COVID because it took a while before those vaccines came out. And again, because of what Dr. Pappas just told us, the misinformation campaign, all of that has caused people to be very weary of vaccines and vaccination. And so what we saw in that study that just came out this morning is that there's a significant reduction in all vaccines, not just COVID vaccines, across the United States and potentially across Europe as well. And so I'll stop there. That's the extent of my presentation. Thank you.
Well, thank you very much.